Now, for our next speaker, I would like to welcome Dr. Nimish Mittal. Is a good friend of mine and a colleague, and we have connected over the years because we have a lot in common, as it turns out. He is the medical director of the Good Hope Ehlers-Danlos Syndrome Clinic at the University of Toronto. So as you can imagine, we have a lot of shared experiences in going through it, but Nimish has brought forward his experience. He's a specialist in physical medicine and rehabilitation, and his focus is on improving function and quality of life for patients with complex chronic conditions, as we are. And there's not many of us like Nimish and I and Dr. Frank Romano and Maitland around the country. I think that, we've got probably 3 of the 4 with us today. So unfortunately, Dr. Frank Romano had to leave. But yes, very, very grateful for Dr. Nimish Mittal and his time. Please join me in welcoming Dr. Mittal.
Thanks for the kind introduction, Dr. Knight. I think my talk is going to be a nice, perfect segue into what Dr. Henderson has spoken about. As you can see from the title, the diagnostic challenge of neurological symptoms in EDS. Is it CCI versus something else causing an autonomic dysfunction? These are my disclosures. The most important one is at the bottom. By no means I'm an expert in this. I've learned as I go, and I continue to learn as I go. This is where I work. It's Toronto General Hospital. We have a program there called the Good Hope EDS program. It's kind of very similar to other multi-specialty programs that have developed over the period of time. When I started there in 2018, we were a group of 4 people. There were 1 physician, 1 physiotherapist, social worker, and counselor. Now we have a strong team of around 30 people. We have 4 specialists who do assessments for diagnosis of EDS. We're supported by a group of PAs and nurse practitioners. And we have a bunch of medical specialties that also look at specific comorbidities, such as cardiology, gastroenterology, immunology, genetics, respirology. We're trying to get an endocrinologist, but let's see how that goes. Outside of these medical specialties, we also have specialized rehab and psych programs which provide care to these patients who have Ehlers-Danlos Syndrome. We have 4 physios, 2 kins, 4 full-time psychologists, 1 dietitian, social worker, counselor. We're quite lucky in having to develop this program in the last 10 years. And one interesting fact, patients don't have to pay because it's the Canadian healthcare system. It's a social medicine. The downside is the wait times, though. I'll tell you that. Yeah. We were actually just voted by Newsweek as the 2nd best hospital in the world, so I'm really proud of that. Yeah. So, okay. Now, historically, Ehlers-Danlos syndrome in medical literature has been recognized by certain specific manifestations related to collagen, which is also called the core clinical triad. People can have hyperflexible joints. They have skin, which is hyperextendable. It's not going there.
Yeah, so this is a request I got for the next one. Sorry to interrupt.
No worries. Yeah, so, the core clinical triad consists of hyperflexibility of joints, and we have tissue fragility. All righty, I'm going to just wait. Yeah.
Okay.
Well, it's not a problem. I'll skip a few of my slides because Dr. Henderson has already spoken about the imaging and the dynamic imaging and workup for craniocervical instability. So I could possibly just skip those slides. So, yeah.
No, you're good. Sorry. So the next speaker, I'm not going to be able to get you your presenter tools and notes. It's not going to work with our broadcast for YouTube. So I'm sorry about that, but I tried.
All righty. Yeah. So traditionally, we know this is the core clinical triad of EDS. And the reason why it is because these are very easily recognizable features. In olden days, these features don't need any kind of specialized tools. But as with time, with research, we have recognized while these are important features, EDS is a multisystemic disease and it spans along multiple systems. So people present with a variety of other different symptoms. This picture actually kind of very nicely quantifies the length and breadth of symptoms that a person with Ehlers-Danlos syndrome could have. In the center of it, you can see like there's hypermobile joints, they can subluxate, they can dislocate. But what it is that over the period of last 20 years, we've recognized it's not just that. It's people can have gastroenterology complaints, IBS-like symptoms. They can have mast cell-related symptoms and allergies, autoimmunity. Of course, they have chronic pain. They can have cardiac dysautonomia. They have anxiety and poor sleep. Of course, if anybody has having all these kind of symptoms, it tends to play a role in their mental health as well, which results in all these symptoms. Effectively, what happens is this is a person with EDS. They're kind of like juggling several medical challenges, and all of this requires a delicate balance of maintaining their lifestyle while addressing their symptoms, managing their daily activity, and so on. Moving on to this slide about the neurological symptoms. Now, I want you all to think about a person like we commonly see in clinic, a patient who has either Ehlers-Danlos syndrome or generalized hypermobility spectrum disorder, who comes to us with a host of neurological symptoms, which are typically called as cervicomedullary syndrome or cervicomedullary symptoms. You know, people would complain of headaches, constant, chronic. They would feel neck pains. It's kind of like a coat hanger pain, which goes along the hanger. They have all these associated, it feels like their head is wobbling on their neck. They're not able to hold it. Then comes with a host of visual symptoms, blinders, floaters, dizziness, and tingling and numbness going down the upper extremities, lower extremities, swallowing deformities, and so on. So this is what a person comes to us and presents with, typically the symptoms which we call the cervicomedullary syndrome. Now, one could argue whether this is it a unifying diagnosis, or unifying pathophysiology, which is responsible for these symptoms, versus these are part of a multisystemic issue. One could say, you know, dizziness and lightheadedness is because of POTS. They have TMJ pains, or they have, let's say, neck pains, which are muscular or myofascial in nature, because of which they're getting headaches, or occipital neuralgias because of their hypermobility, versus having a unifying pathophysiology. And that unifying pathophysiology could be craniocervical instability, which I'm not going to go into detail because it's already been covered, or an altered mechanics, whether it's an alteration of cerebral blood flow, which is caused due to an autonomic dysfunction. Again, if a lot of people who were here yesterday, Chip Norris talked about it, a couple other people spoke about it, what exactly is hypermobile EDS, and is it only just a structural disease versus it's a neuroimmune disorder which is responsible for a variety of symptoms that happen in hypermobile EDS and HSD specifically. So I'm just going to go over this 2 slides very quickly now. Cervical spine is the top 7 vertebrae in our spinal column. It's the most mobile part of our spine, and it's held in its place by a variety of ligaments. It's typically divided into the top part, which is the C0, C1, C2, and the lower part, which goes from 3rd vertebrae to the 7th vertebrae. It allows, this part of the spine provides us the maximal range of motion. So while it provides range of motion, it also has to provide stability so that the segments are not moving untowardly, and that stability is provided by these variety of ligaments, the alar, the apical, the transverse, and so on. And the other thing is, and it has to go through a variety of stretch, and that's a duplicate from Dr. Henderson as well. I saw he had it in his slide too. Yeah, so it goes through a variety of tractional influences through which the cervical spine has to tolerate. This diagram explains the continuum of cervical spine instability in a person who has hypermobility or pathological instability. Like a lot of people, it starts with people who have asymptomatic hypermobility. So in young age, when people have hypermobility of different joints, they may, however, with that, there may not still be any segmental pathological mobility causing them any symptoms. But as it kind of progresses and evolves, they start having mild instability when the spine, when it moves, or the cervical spine segment, when it moves, Even within the normal physiological loads of spine, it is behaving abruptly, and that causes pains and spasms, and these spasms cause pain. As this situation evolves over the period of time, it starts compressing the nerve structures and the brainstem structures, and then people start having autonomic symptoms, radicular symptoms, and eventually they start having bulbar cerebellar signs. I'm going to revise this imaging if you guys want. So now we have a patient who's presenting with these symptoms, and craniocervical instability comes, of course, on our minds, is that is what probably is playing a role in what is happening in this patient. Now, there's a variety of radiological matrix and indices that have been described, but the current accepted, as Dr. Henderson also mentioned, is this dynamic MRI or dynamic CT scan, in which we look for four different matrix, and out of which two, as he said, should be abnormal. And there has to be some objective measurement of this instability for us to confirm conclusively whether it's craniocervical instability from a structural perspective. The first one, as you can see here, it's called the basionaxial interval. You draw a line from the C2, the base of C2 and the posterior inferior part, and you see the base of the clivus, the distance, what is between them, should be less than 12 millimeters. The second one is the same thing you're looking at, but instead of looking at the distance, we're looking at the angle that it creates with the clivus, which should not be less than 135. Before I even go there, broadly, if you think about any movement, it can happen up and down, front and back, or side and side. So those are three planes of movement that would potentially happen. Of course, there's a rotational angle movement as well, but these are the ones which truly happen mostly. The third one is the basion-dense interval, is the distance between the basion and the dense, and the last one is the distance that this odontoid, or the end of this line, which is coming from the posterior inferior margin going to the basion, the distance of this line from the ventral part of the dura mater is, and that changes between flexion and extension.
My apologies.
No problem.
Just briefly.
Yeah, so these are the four radiological matrix which help us understand whether there's structural craniocervical instability or not. And when we started the program, when I joined the program, not when we started the program in 2018, we used to have a lot of patients who would come to us and have these symptoms, and they had EDS or they had generalized hypermobility spectrum disorders. Now, there was not a pathway which existed in our place to help these patients, and there was not a lot of interest from either radiology or from neurosurgery to take a look at these patients. So some of the patients who had means, they went on to different parts of the world, including US, Germany, and other places, to get their imaging done.
So which slide were you on? I'm sorry.
I was on the slide.
So it's a long story, but I was trying to get presenter tools for one speaker, but YouTube won't let it. So we were just getting the camera view on the YouTube. So this is why I had to come in and do it. So my apologies.
No worries. Yeah, so that is what is, again, this is Dr. Henderson's work from 2024, 50, he also showed in his slide. If a person has structural craniocervical instability, as he documented, outlined, there are several other testimonies, it works well. And this is a consecutive sample of 53 patients. This is the 15-month data on all of them in terms of head pain frequency, head pain severity, neck pain frequency, and neck pain severity. On the x-axis, 1 means their symptoms very much improved, 2 means they much improved, 3 means they improved, 4 is not baseline, and 5 is mild worsening, moderate worsening. And you see, in all of those domains, most of those patients had really good outcomes in terms of after their occipital cervical fixation. Just the only caveat was here in these patients who had neck pain severity, you see around 13 patients had worsening of their symptoms, but it was kind of like mild. Now, as I was going back to what was happening in our case, is that we had these patients who had EDS or hypermobility spectrum disorder, and they had these host of neurological symptoms, which we believed was because of craniocervical instability. And they also had, some of them who had the means, they they had imaging from other places in the world which showed that they had instability. But the neurosurgeons were not really inclined. So through the institutional push, we were able to get a board constructed which had 4 neurosurgeons, 2 neuroradiologists, and our EDS team. I get scared now. As soon as I see you, I'm like, what?
This is a true presenter.
Okay.
Oh, we're not going to want to go to the next slide. So boom, there. All right. Thank you, everyone.
Well,
I try to give everybody what they want, and I wasn't going to be here at 9:30 because I have responsibilities, and I didn't want to lay that on board.
thank you. All righty. Yeah. So we had this board constructed, and out of the very few patients, and they were not in double digits, who had their imaging available to us, we send it. So both of the neuroradiologists, and just so you understand, like one of those neuroradiologists used to be a chair of John Hopkins before coming to Toronto. So they were all people who had good experience, and one of them included Dr. Michael Failings, who is also a well-renowned neurosurgeon globally. So all these 4 neurosurgeons, 2 neurosurgeons looked at these radiological matrix independently without knowing what the other one did, and 2 neuroradiologists also reported it independently. And interestingly, their findings between 4 of them were very much similar in terms of these radiological matrix, but were very different from what was reported in US or anywhere else at other EDS centers. Long story short, they were reported as pathological in other places, and here none of them was reported to be pathological. All these radiological matrix domains were reported as normal. So now we were stuck in the place where we want to help these patients, but we don't have any structural abnormality for craniocervical instability based on 4 people who have individually looked at it independently, and were blinded to other reviewers as well. For a couple of them, we even went one step ahead, and we sent them to our colleagues in the US at Feinberg School of Medicine, their spine chief, who does a lot of these surgeries, and their findings were very similar to the findings which were reported in our other colleagues. So now we're stuck in a situation where they have these symptoms, but it's not craniocervical instability. So then we started looking at like what's going on then. Oh no, I think this pointer is not working, but it doesn't matter. Yeah, this would work. So going back to the concept of autonomic dysfunction, which is well recognized in Ehlers-Danlos syndromes, patients who have, people have chronic pain. Because of chronic pain, they have deconditioning. Because of deconditioning, they have their heart size shrinks. They have reduced stroke volume, which results in reflex tachycardia, causing some POTS. There's also reduced venous return when they stand. Specifically, a lot of these complaints in patients happen when they're sitting upright or when they're standing. So it's posture related. So then these people have a lot of venous pooling in their blood. Now we don't know if this venous pooling is because of the laxity of the veins, or is it because of an abnormal alpha and beta adrenergic system response, which is a physiological response that happens when we kind of stand or sit. And that is what we wanted to investigate. Now, just quickly to show you how the blood flow in our head works. The hypothesis we were working on is if these symptoms are related to the blood flow in the head, which is called the cerebral blood flow, which is a proxy marker of the perfusion pressure inside the brain, which I'm going to talk about. So broadly, in simple words, there's the vertebral artery, there's internal carotid and vertebral. These are the arteries which supply blood to the brain. And then there's a mesh of superficial and deep veins, which kind of drain that blood out, going to the deep sinuses, and then through the internal jugular, it comes out. On top of that, independent of that, inside the brain and central nervous system, there's cerebral blood, there's CSF, or the cerebrospinal fluid, which is quite important, keeps it hanging in its place. And what happens with this is because of these arterial flow coming in, CSF pressure, there's something standard called as cerebral perfusion pressure, which maintains itself and is autoregulatory. It's important for the nutrition of the brain and other features. Now, there's several autonomic influences on that cerebral perfusion pressure. as I said before, there's myogenic influences, which are typically, if you would understand, like when there's increased blood flow to the brain, the receptors, they kind of stretch. That results in contraction of the walls, or vasoconstriction reduces the blood flow, and vice versa. And then there's also these alpha-adrenergic receptors. What they do is when there's venous pooling, they increase the resistance in the lower extremities to try to push blood up faster, and they also constrict the vessel walls. And then the beta receptors increase the cardiac contractility. So if there's a kind of like a short circuit in that system, if it's not working properly, that could also result in altered blood flow to the brain, and kind of like different, which kind of alters the cerebral perfusion pressure. Now, again, in the same thing, you see if there's depending on this is the model to show, I think, okay, here we go. So yeah, so this model shows like in case there's reduction in cerebral blood flow or cerebral perfusion pressure, that kind of triggers autonomic nervous system. The parasympathetic nervous system results in brain vessel dilatation, which increases the blood flow and kind of loops it back, maintains it again. The other system is sympathetic nervous system, which I mentioned was like the alpha and the beta adrenergic system, which works on to increase our blood pressure and heart rate, again, manages the cerebral blood flow. Now, these are hypotheses, and we kind of look at it through transcranial Doppler. We can look at the cerebral blood flow in the middle cerebral artery. Now, there's some studies which have actually looked into it to comment on what the cerebral blood flow might look like. The study is from 2021, and what they did is this group works predominantly in Netherlands on ME/CFS. But as part of the data, what they looked at, they had 100 female participants. They actually had 101 participants. There was only one male. So then they took out the one male and they said, we'll keep a cohort of 100 females in this group. So 100 female participants with ME/CFS and hypermobility. Now, they did not look at EDS specifically, but they examined everybody, and each person had to have a Baden score greater than 6, not 4, not 5, but 6. And then the comparison group was there. They already had a lot of data on ME/CSF patients. So they matched the controls for age, sex, and duration of disease. So all patients have similar duration of disease of around 11 years. And so what they found, and what they did is they ran everybody through a tilt table testing protocol. So each patient was kept supine for 20 minutes. And after that, they were gradually raised up to a standing tilt of around 70 degrees for 30 minutes, approximately, depending on how much everyone could tolerate. And they measured the cerebral blood flow in both internal carotids and both vertebrals. And there were 5 or 6 measurements, each lasting for 1 to 3 minutes, that were done during this time. What they found is that, on the x-axis, there's two different bars. One is more red, less red. On the left side is the bar where people were all of them had ME/CFS, but on the left side, people had hypermobility. On the right side, people did not have hypermobility. And as you can see, the percentage reduction in cerebral blood flow is very high in people with hypermobility as compared to not. And it was statistically significant. The other thing what they looked at is also quite interesting, is that they also now looked at whether these patients had POTS or these patients did not have POTS and have normal heart rate, which interesting findings again. It's like people who have hypermobile patients with POTS had higher reduction as compared to non-hypermobile patients, but ME/CFS patients with POTS. But you would expect that because they had POTS, they would probably do it. But another finding was that people who did not have POTS also had a higher reduction in cerebral blood flow, which is increasingly being recognized as orthostatic hypotension. And not only orthostatic hypotension, but it's being recognized that people who have orthostatic hypotension, they may not have POTS, but they still have severe autonomic findings and cerebral blood flow. So people who don't have POTS can still have dysautonomia, which can result in altered cerebral blood flow and responsible probably for the symptoms. Another retrospective study, single center, 270 patients. This is quite recent in 2025. Looked at, these were 270 patients with geneticists confirmed hypermobile EDS, and the comparison group was healthy controls from a research database. They looked at a lot of autonomic function using Brigham protocol, and on this side, so they initially started with approximately 3,861 patients, but at the end, final analysis was for 270 patients. Only thing I want to show you is this was the cerebral blood flow velocity they found in people, healthy controls. And this was the cerebral blood flow velocity they found in people who had Ehlers-Danlos Syndrome. And what they said is that tilt-up test induced a greater decline, as you can see in cerebral blood flow in HEDS patients as compared to the controls. The other finding, which is quite interesting, is that the orthostatic cerebral blood flow predicted the lightheadedness and dizziness, but there were a bunch of other variables that they had which did not predict any kind of autonomic failure that that patient had, did not predict their cerebral blood flow. It was only orthostatic findings that predicted their lightheadedness and their other symptoms, which gives us insight into that there might also be an alternate mechanism that could be responsible for the neurological symptoms a person might have. Well, those were all the learnings from us. We have now drafted our own protocol. We are recruiting our own patients. We are studying, what we are studying now is whether the symptoms these patients experience are from a vessel wall fragility, or whether they are from an abnormal autonomic nervous system in terms of alpha and beta adrenergic responses. Once we have better understanding of that, it might lead us to some therapeutic options that could help modulate those systems and have better control of symptoms for these patients. Thank you so much.
Yeah, we do have time for a couple questions. Again.
Great lecture. I want to have time going back to the trial, but talk about the physiologist, right? And then when you talk about hypermobility, again, immediate hypersensitivity plays. I just want to roll this into an observation that was done at Brigham women, where they took individuals that had hyperalpha-ischemia and also had autonomic neuropathy. And half people also have tendency to be hypermobile.
Yeah.
When they put them on the tilt-table test, they had the same findings that you had. So I think it's important to kind of include all three aspects to understand that the integrity of the connective tissue is tied into glucose regulation,
Totally.
as well as
Totally. So I'm going to repeat the comment for the viewers as Dr. Maitland is talking about how the whole aspect of, or the holistic part of the connective tissue disorder is not only related to structural instability, but ties well into the autonomic neuroimmune hypothesis that kind of plays a role in the symptoms a person experiences. All right.
Question. Yeah, back.
Great question. So the question is whether hiccups, if there's any correlation between hiccups and craniocervical instability and autonomic dysfunction. We have seen patients who have this in my experience, but we don't have a better understanding of what is. Initially, what we were looking at is some diaphragmatic function, and if there was abnormal diaphragmatic function, but that came out to be completely normal. Now, is it a vagal nerve play, and is that vagal nerve play because of an autonomic dysfunction due to CCI versus an autonomic dysfunction just because it's dysautonomia? I'm not aware if there's any available information on that. If there's any other, experts who want to comment, I'm happy to hear.
One last question. Yeah, Joe.
You're asking about the structural piece of it? No. So yeah, the question is if there was any between the cerebral blood flow velocity, if there's any correlation with pain and other or pain-related findings. I don't think there was.
Thank you, Dr. Mittal.
You're welcome.